And the least people like is the kind that we have.
Great team. Oh no!
I should have put the wine.
I had my phone down. I had the phone put down.
Don't let Larry off the see that. I'm working. Don't put me on the video.
So, when
So, I didn't know we had NTV here.
Just if you want to come on CBC News tomorrow.
I was going to say, Dr. Joshi, have you arranged some press coverage for yourself there?
Yes, just 2 minutes. He's the best coverer. He's going to be a advertiser for
just a few minutes, just to keep the memory alive, eh?
That's so
Of what we
sweet.
do in Grand Falls, right?
Yeah.
We take pictures. This is a smart idea. Because
Oh my gosh, it is, and we're in the press.
Excuse me, sir. I'm leaving neurology.
He's a video cameraman in training.
He's looking for tremors. Go on,
The man there is demonstrating for him.
Yeah,
He's doing a good job. Gestures with his hand.
let's see right behind you. Yeah, behind you.
even nice. From the one that's the one that's killing the It's snoring loud.
Smoking is definitely not.
No, we're not that bad.
The record showing.
I might make you up this.
It's all right. I'm not here.
That's how it is.
French style cheesecake.
You know what? Because
He doesn't want to be. Just, yeah, he wants to choose himself.
Yes, there is one there. It's just you guys.
He was going to come to this for the college. Very good things about you that you say. He hasn't talked.
The night of young today. It's a brunch.
I've been saying.
Oh, yeah.
He always says they never told him. I get that checked. That's not a problem.
To find the bulls in the bush.
I'm glad you said Dr. Joshi Nl.
No, but I mean, honestly, I'm worse than him. You know, I go around and
You have played with him yet?
Peter Hamilton gave me his How can that be?
He's lucky. He's a phenomenon. He hasn't played with him yet.
Peter Hamilton gave me his best his trusted. Because I told him that I play with two handicaps.
Plays with these oversized balls.
Once you have played with him, I'll give you angels.
Are included in this percentage. Diabetes is a cardiovascular disease primarily. So this is the progression of a plaque right from inception, from the first decade of life, and right up to the final event, which is coronary thrombosis. And just to give a brief history, what happens is, as long as the endothelium is functioning normally, which is, depending on lifestyle, could last longer or shorter, there is no contact between macrophages and lipid-rich particles or lipoproteins between the various layers of the vessel wall. But as more and more LDL particles start floating around in your bloodstream, these LDL particles actually start migrating into the intima, and as they migrate into the intima, they also undergo oxidative stress and they get oxidized. Now all that is not shown there, but what happens is that the oxidized LDL is actually start to secrete cytokines, and the cytokines start to cause migration of macrophages from the lumen into the vessel wall. These macrophages are known as foam cells because now what they do is they engulf these lipid-rich particles, which is the beginning of the atheromatous plaque streak. And as this process goes on, the smooth muscle cells, which are in the media, start also migrating into the intima of the blood vessel, and they start proliferating. And as they start proliferating, the plaque develops a fibrous cap. And this is a cycle that repeats itself multiple times. And during this process of replication, also there is programmed cell death or apoptosis. And as the cells die, this fibrous cap could actually become weak, depending on how much tissue is fibrous and how much is lipid. So in a cap which has very little fibrous tissue, that has now a thin cap. And a thin cap atheromatous lesion is at high risk for rupture. If such a lesion ruptures, then the lipid-rich core comes in contact with the blood. And as a result, the coagulation cascade is activated, and you have coronary thrombosis and ultimately myocardial infarction and death. Now, up to now, these are our key studies and trials. Okay? And here is the increasing risk of coronary heart disease. And if you look at the trials, we started with this. This is the landmark study which was published way back, probably. Coronary heart disease and high cholesterol. That's where we started. The 4S, the simvastatin Scandinavian study. And as time has gone on, we are seeing studies from high cholesterol to average cholesterol to this HPS, which is the heart protection study, which we'll talk about in a little bit more detail, where the patients really didn't have always coronary heart disease. They had coronary heart disease risk equivalent. That means they were at high risk, but didn't really have history of myocardial infarction always. And the cholesterol levels were no longer high, but were average or maybe even low. Then came CARE study, where they had coronary heart disease, but didn't have high cholesterol. Then we had the WASCOT, the West of Scotland study, where again there was no myocardial infarction, but they had high cholesterol. And then the APCAPS, TEXCAPS, lovastatin studies, where they neither had coronary heart disease, nor did they have high cholesterol. So we have moved from these, which were the secondary prevention trials, to these, which were basically primary prevention trials, showing benefit in reducing cardiovascular disease. Okay, so these are the endpoints of some of the major trials in primary prevention, as we mentioned, FCAPS, WASCOP, secondary prevention, 4S. And then in early 2000, we started to see some ischemia-related trials, where the statins were not only improving cardiovascular mortality, but they were actually reducing cardiovascular ischemia. The Miracle study is sent actually shockwaves to cath labs in the United States, because 80 milligrams of atorvastatin was actually better than angioplasty in reducing recurrent cardiovascular events. And in all these trials, you can see the CHD risk reduction is anywhere from about 26% to about 40%. Okay, we'll briefly talk about the heart protection study, where they took about 20,000 patients. These were all high-risk patients, defined as either they had coronary heart disease, or they had peripheral vascular disease, or they had diabetes or hypertension. What was not common was what their LDL level was at baseline. Some had high LDLs, some others had average LDLs, and some of them even had lower LDLs. They were randomized to either simvastatin 40 milligrams, or they were put on placebo, which also included actually a vitamin AM to see the effect of the antioxidant, supposedly antioxidant effects of vitamins. And they were followed for 5 years. And what we found was that there was significant reduction in not only on-cause mortality, but also cardiovascular mortality, coronary events, stroke, and revascularization rates. Now this risk reduction was seen at all levels of LDL, whether you had high LDL, whether you had average LDL, or even whether you had low LDL. We started to include more and more older patients, and the study also clearly defined that diabetic patients did as well as those who were not diabetic. And if you look in terms of where they were at baseline in terms of their LDL cholesterol, those whose cholesterol was quite high, more than 3.5, and those whose cholesterol was considered low, even by today's standard, less than 2.5, they both benefited the same. The reduction was about the same. So clearly, here we had a study that said that if you were at high risk of coronary heart events, it wasn't important where your LDL was started off, as long as you were a high-risk patient, and we treated with equivalent of 40 milligrams of simvastatin. Another interesting study published recently is the study, which is a pravastatin study specifically designed to see the benefit of statin therapy in elderly populations. So they took, by any standard, elderly folks at high risk, randomized them to pravastatin 40 milligrams or placebo, and then followed them over time and found that there was about 25% reduction in coronary heart death, 25% reduction in TIAs. They didn't find stroke reduction in this study. So this study specifically showed that being an elderly did not disqualify you from receiving statin therapy. Okay, now we'll branch off a little bit and talk about ALHAT. Now this was big news for 2 years, and basically ALHAT is an antihypertensive trial, but they also had a lipid lowering arm. And more than 10,000 patients actually qualified for the lipid lowering arm, and in this arm they were actually treated with pravastatin, which was non-blinded, versus usual care. And they didn't find any reduction in major coronary events. And so this study, which was published 2 years ago, was at variance with some of the other studies. The reasons for that, for the sake of time, won't go into. Okay, this is the other large primary prevention trial that we had.
If you go back to the study just before that, can you explain why the reduction of MIs was greater in the moderately high LDL?
No. Yes, it's there, but I think that's just that's chance. That's chance. It doesn't mean that people who have between this 2.5 and 3.5 are going to do it better than those who have higher or lower. That's just chance. So coming back to this, ASCOT is Anglo-Scandinavian Coronary Outcomes Trial. Again, this was, and actually this study is still ongoing, this is basically an anti-hypertension treatment study. But in this they had a large arm, about 10,000 patients, who were randomized to lipid-lowering trial. Of these, 5,000 were assigned 10 milligrams of atorvastatin, and 5,000 were assigned placebo. What they had to do was, these patients, all those who were accepted for randomization, were all hypertension patients. Okay, they didn't have coronary heart disease, no history of myocardial infarction, no history of previous LV problems, etc. But what they had was high risk. So they had to have hypertension and 3 other risk factors which put them at high risk, which could be male age, premature family history, being more than 55, history of stroke, something of that sort, but no previous history of coronary heart disease. Then you got on to either atorvastatin or placebo. And baseline characteristics of all these patients were quite similar. They had a lot of women, a lot of folks. As you can see, their LDLs, both placebo and the atorvastatin arm, were about 3.4, which you would not say is exceptionally high. Glucose were about the same, medical history, 24% diabetics, other 24% non-diabetics, some of them LVH, roughly in same proportions. And then they were followed for, they were supposed to be followed for 5 years. The study got stopped before that. This is their baseline cholesterol levels. The total cholesterol at baseline was 5.4. The LDL was 3.4. HDL was 1.3, and triglyceride was 1.6. So nothing terribly exciting, not very high. And of course the placebo were similar, 5.4, 3.4, etc. At the end of the study was supposed to go on for 5 years. So the study was stopped at the end of 3.3 years. At the end of the study, the total cholesterol, the atorvastatin, was reduced by about 1.3 or so to 4.2. LDL was reduced by 1.1, so here, and this didn't change much. The HDL 1.3, 1.3, and triglycerides slight reduction. So in the placebo arm, of course, there's going to be a difference. Those who started with an LDL of 3.4 remained at 3.2. Again, not very high. But this was the composite of primary endpoint, the total of myocardial infarction, fatal and non-fatal coronary heart death. This is the placebo arm, and this is the atorvastatin arm. There is a 10 milligrams as opposed to those who did. And the study was stopped here. The hypertension arm of the study is still ongoing. So we have clinical evidence, a very large trial, very recent large trial, showing that patients who do not have coronary heart disease even, may not even have high cholesterol levels, high LDL levels, as long as they have enough risk factors to qualify for statin therapy, we should put them on statin therapy. And of course, this is reflected in our current guidelines. And if you look at the secondary and tertiary endpoints, atorvastatin better or placebo better, of course, primary endpoint being fatal, non-fatal, CHD better, coronary events better. What was not significantly different was all-cause mortality. It was reduced 13%, but this was not statistically significant. Patients with chronic stable angina, you see, they did almost as good as the overall study. This is in keeping with some of the ischemia studies we have seen with statins, such as Miracle and ours. That not only can you use statins to reduce cardiovascular death, you can also use them to reduce coronary events, which may result in, say, angioplasty or need for revascularization. So, because of this trial, the guidelines have evolved. And last year, in December, maybe around this time, when Dr. Barry in fact was here, the Canadian guidelines got updated, and they reflect these changes that we are talking about. And overall trends in the lipid management guidelines is you treat a larger and broader group, you take elderly folks, you take all your diabetics, you lower the LDL targets, and you try to get to more effective therapy. So what were the changes that came out last year in the lipid management guidelines? The first major thing is that as opposed to what we did in the NCEP 2 guidelines, NCEP stands for National Cholesterol Education Program in the United States, we used to just add the various risk factors and say, okay, if you have 3 risk factors, you get an LDL level of this. If you have 2 risk factors, you get to an LDL level of this. Now we are going by the classic Framingham tables, the Framingham study, and calculating the global risk of the person instead of just simply adding up the individual risk factors. And then we decide based on those Framingham points whether the risk is low risk or medium risk or high risk, but it is in terms of hard cardiovascular points. And we also, importantly, reduce the primary targets of treatment to just 2. You target the LDL and you target the total cholesterol HDL ratio, because, well, most studies were done on targeting LDL, so you had to have an LDL target. And total cholesterol HDL ratio is actually a more sensitive marker of cardiovascular risk than LDL, and that's why it is there. Now, triglycerides were taken out because you cannot get this ratio unless you treat triglycerides anyway. So by reducing the number of risk levels, previously there used to be a high risk, a moderately high, and then a moderate, and then the low risk. We reduced it to just moderate, high, and low. And we reduced the target level to just 2, just to simplify the guidelines. You've seen these Framingham tables. This is how you calculate risk for men, the same as for women. Of course, patients who have history of cardiovascular disease or have diabetes are automatically considered as high risk. But for everybody else, you've got to sit and add these points to know what their risk is. If somebody comes to your office and says, what should be my cholesterol? Is it high or is it low? Unless you know these tables in your mind, you should say, I don't know. Because I'm going to have to pull out this piece of paper and add up your points and then decide as to where you fit. So the Framingham tables basically take 5 major categories when you decide on risk: age, the total cholesterol, the smoking pattern or history, whether you are treated with hypertension or not treated, you get different points, and of course your HDL. LDL of course doesn't fit because you're using these tables to decide where to target your LDL. And then you come to this total points and you decide how much risk. Less than 10 points is low risk, or up to 10. Okay, more than that, less than 20 is your medium risk profile. More than 20 is the high risk. What we are saying by using these terms is saying you are at low risk for a 10-year cardiovascular mortality. When we say you are high risk, we are saying you are at high risk for 10-year cardiovascular mortality. It's 10 years. It's not 20 or 30. And similarly, we have for women, the difference is only in the number of points they get. Otherwise, it's the same thing. Low, medium risk, less than 10, 10 to 20, and more than 20. And of course, the guidelines want to make everybody aware of this syndrome, which I'm sure you're all aware of, metabolic syndrome. The person looks like a pear, probably has metabolic syndrome. And why do we wonder about this, and why is this important, is because if you classify somebody as metabolic syndrome, he's automatically at high cardiovascular risk. Okay, because metabolic syndrome is actually a clustering of all these cardiovascular risks, right? How do you define metabolic syndrome? They are hypertensive, they have insulin resistance, they are obese, okay, and they have dyslipidemia. Although it's not the high LDL kind of dyslipidemia, they usually have low HDLs and they have high triglycerides, okay? So once you know that you come across a patient, you automatically know that their risk of cardiovascular death is actually twofold. And even if they don't develop diabetes, that risk still stays there. Because diabetes is often an end point of this process. They already have developed cardiovascular disease. They may still have just glucose intolerance. So the fact that they didn't develop hyperglycemia doesn't change the fact that they are at high risk of cardiovascular death. Okay. So this is the meat and bones of the guidelines, right? High LDL less than 2.5, target of the ratio less than 4, moderate risk 3.5, low risk 4.5 and 6. Anybody with history of diabetes, adult patient with history of diabetes, or evidence of any other atherosclerotic disease, for instance, carotid artery disease, peripheral vascular disease, history of stroke, all those are atherosclerotic diseases and automatically put a patient in the high risk category. Similarly, chronic kidney disease, any patient who is on dialysis, all these patients automatically get classified as high risk patients. For the rest, you got to look through your Framingham tables to decide what their risk is. Okay, after that came this latest literature, which is going to create a great deal of, the study is making big waves. Okay? This is statin or statin evaluation infection therapy is going to result in a change of the guidelines I just showed you. This was a 2-year study actually, where they took patients who were admitted with an acute coronary syndrome, myocardial infarction or non-ST elevation MI, and within 10 days they randomized them to either a moderately lipid lowering arm or an intensive lipid lowering arm. The moderately lipid lowering arm was the pravastatin 40 milligrams, and the intensive lipid lowering arm was the 80 milligram pravastatin arm. Okay, and the primary endpoint obviously was death from any cause, need for revascularization, rehospitalization, stroke. The study was actually designed by makers of pravastatin. It was designed to show that it is not the LDL reduction that results in cardiovascular outcomes, but the fact that you are on statin and the other benefits that statin has. For instance, they are anti-inflammatory drugs and they reduce CRPs, etc., etc. And it was also designed to show that pravastatin is equivalent to high-dose atorvastatin. So this is the way the trial was actually designed. And the primary endpoint for a patient wasn't that they were going to have these events. Of course, they were going to have these events, but the time it took from randomization for them to have a first event, that time was actually the endpoint of this study. And also in this, you see it says infection therapy. They also had an arm where they actually gave people antibiotics for 10 days each month that they were on in the trial to see if it would make any difference. I've never seen any published data on that, so I don't know what happened to that. It's compared to baseline. Patients who were on atorvastatin, 80 milligrams, saw a reduction of about 40% of their LDLs, and those who were on pravastatin saw a reduction of about 10%. And at the end, when the trial was stopped in 2 years, those who were on Pravachol had a median LDL reduction of about 10%, and they got to 2.4. That's what our guideline says. They should be below 2.5. Their event rate, that means time from randomization to the first event, those who got Pravachol, their event rate was 26%. Those who got high-dose lipid-lowering therapy, their median LDL reductions were 42%. Their LDL was down to 1.6. And their event rate was 22%, which gave atorvastatin further 16% risk reduction. Okay? This difference was evident in 30 days. In 30 days, patients on high dose atorvastatin did better than the standard dose pravastatin. Okay, I'll show you another interesting study. This is reversal, which is actually a study of the atheromatous plaque itself. It's not a clinical outcome study, where what they did was they took about 654 patients who already had history of coronary artery disease. They had coronary artery plaques. They randomized them, and to half of these they gave pravastatin, the other half they gave atorvastatin. The baseline LDLs for, I think, both arms was about 3.9, and what they wanted to see was what is going to happen to that plaque. And what they found was, in the end, there were changes in the plaque, and that they measured by means of intravascular ultrasound. So again, the LDL reduction with high dose atorvastatin was similar, 46%, pravastatin 25%, and at the end of the study, the authors concluded that patients who were on atorvastatin had no progression of the plaque. There was a reduction in the plaque size, so that the plaque didn't progress, whereas patients who were given pravastatin actually had progression of the plaque. Again, not a clinical outcome study, but a very interesting study, actually looking at the plaque. So, what is new for our high-risk patients? Remember, this is where the guidelines just came out saying, your regular goal for high-risk patients should be less than 2.5. Now we probably should be doing this. For those patients who are very high risk, we should say your goal is less than 1.8. In the proven studies, they got down to an LDL of 1.6, which is almost 1 whole millimoles per liter below what your guidelines tell you. Okay, so for LDL more than 2.5, we should start LDL lowering therapy at the same time as lifestyle changes. I think we all already do that. But now for patients who have history of coronary heart disease, a high risk, for them, even if their LDL is less than 2.5, drug statin therapy is now a therapeutic option. And of course, if they have a different form of dyslipidemia in terms of high triglycerides and low HDL, then you would consider combination therapy with fibrate. Okay, so who's the candidate for this? So all your very high risk patients. These are easy, right? Established atherosclerotic disease, right? Peripheral vascular disease, carotid artery disease, and chronic kidney disease. All those patients automatically go here. Also, all patients with acute coronary syndrome. Many patients have no previous diagnosis, right? Are diabetics. And importantly enough, not every statin is created equal. Some lower, as we show you in some of the pravastatin trials, some only lower at 10%, 25%. And some others do a better job of that. Okay, so I'm just going to show you a brief efficacy study, which is a stellar study. It was published in the American Journal of Cardiology last year, which is basically a comparative study of the various statins. They took about 2,400 patients and they randomized them to 14 groups. They got baseline LDLs and then they followed them for 6 weeks and then repeated their LDLs. And then they assessed these changes to see how efficacious these various statins were. So they compared 10 mg of rosuvastatin to 10, 20, 40 of atorvastatin and higher dose comparatively to the higher doses of atorvastatin. 10 mg of rosuvastatin, 10, 20, 40 of simvastatin, and then the higher doses of rosuvastatin with the higher doses of simvastatin. Pravachol only comes up to 40, so we compared 10, but these are the same. This includes rosuvastatin. And this in particular was shown later on to have been used incorrectly because most of the cases of rhabdomyolysis which actually occurred with this drug were where it was not supposed to be used. It was not supposed to be used with gemfibrozil, and it was used with gemfibrozil, and so this is what happened. And now in fact we say that if you're going to use combination therapy with a statin, you should probably not use gemfibrozil.
Did it compare with rosuvastatin in its efficacy in lowering LDL? Rosuvastatin, Bake-Off.
No, in that chart it wasn't there.
No, that's right.
But its efficacy was somewhere between Pravachol and simvastatin. It wasn't much more efficacious. Not as efficacious as even atorvastatin.
Would you comment on the fact that the guidelines that came out a year ago
Yeah.
don't pay any attention to triglycerides?
Yes.
But if your triglycerides are 4.5 or more,
Yes.
for some technical reasons, you can't get an LDL reading?
Yes, that is true. That is true. But your ratio would be high anyway, because to calculate your ratio, you do not need your triglycerides. It just means that you have to get their triglycerides down if you want to get the calculation of their LDL.
Okay, does that mean you put them on the fibrate or something first?
You could do that, or that ratio is not easy thing to treat. You can put them on fibrate, but they're probably going to need a little bit of exercise and a little bit of weight loss in addition to that.
Yes, you can treat them anyway.
So yes, go ahead and give them, your fibric acid derivatives. But if you're not getting them down to the targets, it's because of some of the lifestyle things that we aren't able to motivate our patients to follow.
Dr. Joshi, I just actually pulled a paper on calculating LDL when triglycerides were elevated. And there is a formula, I think it was published in October 2004, for calculating, but you had to have very low lipoprotein. So that means it becomes better off to treat that and then get your measure.
Thank you. Okay, so just a brief comparison of various statins. The most flexible dosing is with atorvastatin. You can give 10, you can give 20, you can give even 40 milligrams. All others should be 10. If you ask me for my personal opinion, if you're going to use atorvastatin, you either use 40 milligrams or you don't use it at all. Okay? You can give them without food. Most of them are given in the evening. Some you can give in the morning. Almost all carry the same warning for renal toxicity. 10 milligrams is the maximum dose that you can give. For hepatic toxicity, 20 is the maximum you can give. Some of them with CYP pathways, some don't. The simvastatin doesn't. There is interaction of gemcitabine with all these statins. If you're going to use combination therapy, stay away from gemcitabine. Some don't interact with antibiotics or antifungal agents like pravastatin and simvastatin. We don't have much information about protease inhibitors and grapefruit juice, etc. Otherwise, the rest is more or less the same. Pravastatin and simvastatin don't interact with digoxin. And that for our elderly folks who invariably are either candidates or were candidates or are going to be candidates for digoxin therapy, that's kind of important.
A lot of people back from the health sciences on simvastatin.
Yes.
And I've often wondered, why would you use 40 or more milligrams of simvastatin when you could get the same effect? 10 milligrams of Crestor is equivalent to 80 milligrams
I think it's a question of personal preference. If somebody wants to use high-dose simvastatin, well, that's certainly their choice. I mean, it's a good drug. It's been shown, like I showed you, heart protection study shows that 40 milligrams of simvastatin will get your LDLs down. It just depends on where you're trying to get them. If you are going to get them to target, let's say your target for a particular patient is 3, let's say, you could use anything, even a pravastatin. But the lower you are going, that's when the question becomes more important. Which statin are you using and what dose you are using. But if suddenly somebody wants to use simvastatin and he's coming from health sciences,
One of the things about that, though, for us humble GPs is that if Dr. So-and-so from the great center has already hooked them on Zolpidem,
yes,
then, and they're not responding like they should,
yes,
and then some humble GP from Grand Falls says to them,
Illinois.
maybe you weren't put on the right drug in the first place, or some words to that effect.
yes.
They sort of doubt you.
And it could be a little more silver tongue when it comes to patients to die.
Yeah.
You say, oh, well, not every patient reacts the same way.
Yeah. First thing is give them samples. Give them samples from us.
Not only that, it is not clear at this present time that this different statin are equipotent. I don't think that.
What do you mean by that?
By that I mean 10 milligram of Atrova is equivalent to 10 milligram of Simran, or 40 milligram of each. Rasuva may be a little less dosage, but maybe more potent. I don't think that it is improved.
Well, I don't think anybody is particularly looking at potency. We are looking at efficacy. Because at the end, you want the patient to be on an effective dose of the drug, and effectiveness we are measuring in terms of LDL reductions.
But the trouble is with the side effects. You know, if you're going to use 40 or 80 of one, and have tons of hepatic and side effects, if you can get away with 10 of the other, why can't the grandfather GP use the 10?
I didn't say he can. I said he can. He absolutely can.
Yeah.
I said just give him some samples. If you run into
But
patients,
they all reduce the LDL. Just the side effects is the main difference between all of them.
And what you want to do is you want to use the lowest possible drug, the lowest possible dose to get to your target. That's the principle I follow. So if I can get there with 10 milligrams of rosuvastatin, I'll use that. If I think 20 milligrams of any drug will get them, then I'll see what I have in my cupboard. So, and also it depends on what they can afford and what prescription plans they have, etc. Okay. Briefly about C-reactive protein. So it's a sensitive marker of inflammation and is found to be a powerful predictor of long-term diseases, even more than LDL and even more than the total cholesterol and HDL ratio. And that is because these foam cells are actually inflammatory particles, right? Dr. Steve is here. And these...
It's physically there.
Mentally. So these plaques are going to, because they contain these foam cells, and they are rapidly undergoing a process where they are releasing cytokines and provoking a reaction. So it is going to result in elevation of some inflammatory markers, and we have found that high sensitive assays of C-reactive protein are actually good markers of that process. And that this is independent of the lipid levels, as opposed to lipid levels, just having high sensitivity, CRP being positive, affords you greater risk than the overall numbers on your cholesterol profile. And this is what this chart exemplifies. This is your probability of being free from cardiovascular disease. This is the number of years if you followed up, and these are the various numbers. Low CRP and low LDL, you're going to be at the best probability of being free of cardiovascular disease. If you have both high, the worst. But if you have to choose between a high LDL and a high CRP, you're better off with a high LDL than high CRP because there is a significant difference in the event-free survival over there. So now we're not using this clinically as much because we're still getting away with using our LDLs, but there may be certain situations where you may actually want to use a high sensitivity. Yes?
Our lab here, have we converted over yet to the CRP? That's, no. Okay.
It's an expensive assay. Okay, these are some of the other markers in the prediction of cardiovascular events, and this is your Lp(a) and homocysteine over there. Your LDL is somewhere in the middle, total cholesterol above that. The ratio is here, more predictive, high sensitivity CRP is over here, and if you combine high sensitivity CRP with the ratio, then your relative risk is almost close to 6. So we need to standardize this and make it more affordable so that to detect atherosclerotic risk, because we still have, look at this, your total cholesterol is far better than the Lp(a). So why are you looking at Lp(a) when you can actually do total cholesterol HDL risk? The only thing better then this is high sensitivity CRP. Right? This is baseline risk. Doing LP little a is slightly better than that. Okay, what?
ApoB.
Oh, you're talking about ApoB. Oh, I see. Okay, I'm sorry. I thought you were talking. You can do that. That's also a combination of various risk particles. Again, it just depends on lab. Our lab probably cannot measure lipoprotein levels. You know, but you can do it, and there are certain levels. I think below 0.9 is considered good for high-risk patients. But you can do it. But as you see, even APB is above TCHDL ratio. So if you can do TCHDL ratio, why do you need to do ApoB? You could ask, why are we not doing this? That would be a different question, because that is better than this. But that's because it is expensive. And this is still, let's say if this is best marker, this is the second best, this is the third best. The third best is easily available. So we don't need the fourth best or the last best. Okay. Just to summarize things, we are going to actually, AstraZeneca is going to do a rosuvastatin study, which is going to actually follow for primary prevention purposes, and it's an efficacy and safety study for primary prevention, where patients will actually have average LDLs, less than 3.5, but they are going to have high CRPs. And this study is, I don't know, is it already randomized? Are they randomized patients?
Yep.
Okay. So we'll wait for this 10,000 patients. Okay. So this is going to be a big study, the first study on C-reactive protein, where we have actually low LDLs but high CRP, and what is the effect of statin on this. So to just summarize, we started from here with statin trials. I think I was the first year resident when this forest study got published, and now we are here. The placebo patients, okay, this is the event rate, this is the mean on treatment LDL follow-ups. Those who got placebo versus simvastatin, this was their risk. Those who got treatment, they came here. Then we had a bunch of care and lipid trials, which came here in the intermediate risk. And look where PROVE-IT has brought us. If you got pravastatin, okay, this is pravastatin. This is where you were. If you got atorvastatin, this is where you were. In secondary prevention, that means these are patients who already had coronary events. We started from here. When we come to primary prevention, we started with the West of Scotland study. Okay, and now we are down to here, ASCOT study. So, I think the answer is, I think the lower we go with LDL, the lower we are going to reduce cardiovascular risk. We do have to choose our patients carefully. This does not mean everybody should.
Referred to as the lipid controversy years ago, and when it came out, we had many articles about the cholesterol myth. Do you feel that this issue is dead about all-cause mortality? Because now, when the lipid controversy came about, we certainly weren't talking about an LDL of 1.6.
Yes.
And now these issues of I don't hear it anymore, but they used to talk about colonic CA and well, there's even some other crazy things that came up. But I'm not sure we have all the data to show that the naysayers are wrong. That there is some risk associated with that we may not understand. I realize we know about the side effects of the statins, but we do not know. Well, what is the risk of truly lowering someone's LDL to this level?
Zero. Yes, it's a good question. I'm not sure there's a good answer to it. I guess as we go down and as these trials come out, we're going to have to look at who dropped out of the study, what was their other, mortality, etc. We always looked at all-cause mortality. Now we don't mention it because that's built into the composite endpoint of most of these studies. But if somebody's risk of colon cancer is going up, that will always come up. That will never go away. But we haven't seen that, and that's why I think it has died down. Yes.
Okay. Listen, during your presentation, you didn't mention anything about what other people are now describing to be the Alibaba adverse event of this statin therapy. Because now there's now an emerging concern that within the neuropsychiatric realm, it seems that exposure to statin therapy leads to rapid decrease in memory. There have been even some little small studies that have really suggested that these people are really coming down with faster deterioration in their memory than ever. And even in my own clinic, I've seen about 3 or 4 patients who have even come in even to really declare that they don't want to be put on any of the statin therapy again, because right from the inception of the treatment, they have noted that their family loved ones started really on the decline side of the memory. But this is gaining really very great concern within the neuropsychiatry, but it seems that within the cardiovascular realm, nobody is really talking about it.
That's true. I haven't in my reading come across any major concerns of the type you're raising. In fact, the opposite stuff is, there are a lot of data showing that actually if you're on statin, your stroke risk is reduced. If your stroke risk is reduced, then multi-infarct, dementia, and all those processes are going to go down. So I don't know, maybe not having multi-infarct dementia might make up for.
So they call it the memory thief. They call the statin therapy.
I think we'll need more long-term studies, and there may be some smaller studies, but actually there is a small atorvastatin study which showed that patients with dementia did better when they were on atorvastatin. One of the statin drugs, I forget which it was. I think it was atorvastatin. But they did better in terms of memory than the ones who were on placebo.
But I remember two of the patients were really on Lipitor, but I don't know whether this is just a class action type of Alibaba adverse event, or it's just something that is just coming up in those individuals.
I think it's people who get to take the medication and then they feel guilty about it.
Your opinion now on why don't we sell it, some of these, biomarker shops, like pharmacy scripts. Because not many side effects really if you look at it.
Well,